Morning, everyone.
Good morning.
Good morning.
Let's see, we got 1, 2, 3, 4, 5, 6, 7. Okay, I think everyone's here now. All right, so this week, we have some stuff about like skin in general that we're studying for the week. So I don't know if you guys thought this stuff was pretty easy. I'm hoping you did because I feel like we've gone over it before. Um, so a lot of this had to do with, the information process and then just like identifying different types of skin issues. So we're going to kind of go over a little bit of stuff today having to do with that. So to get you a little bit more focused on what you would need to know. I do want to point out a couple of ATI chapters to you guys to make sure that you're looking at your ATI book. So for last week, when we talked a little bit about immunity and HIV and all of that, so in your MedSurg ATI book, the purple one that you guys have, there is a chapter in there, it's chapter 86, and that's specifically about HIV and AIDS. So that might be helpful for you to look at, regarding that topic. And then for today, our stuff that we're going over with the skin, the MedSurg book doesn't really have a specific section all about the skin. It's different. So there is a chapter in your fundamentals ATI book that you could look at for this one. So for this, it would be chapter 55 in your ATI fundamentals book, the gray one. So just make sure you're taking a look at those occasionally because I feel like they make it a lot simpler and sometimes it's just a little easier to summarize everything with this book compared to our big book. Okay? All right. I've had some issues with my sound on my computer, so I don't have my headphones and stuff on today. So I'm going to test something and see if you guys can hear it or not. Hopefully you can. Let's see if I can get it on here. Okay, so there's a couple different concepts that we need to kind of pay attention to today in class. So I want to see if hopefully you guys can hear this. I don't know. If you can't, just tell me and I'll stop. But let me find it real quick. I think it's this one.
Are we supposed to hear something?
Yes, you are supposed to hear something, but if you can't, then my sound must not be working well again.
Yeah, we
But
can.
okay, well, there's still writing on here, so at least read what it's telling you, okay? So let's finish this and then I'll talk about it, okay? Okay, so look at the bottom here. So in your stuff that you had to do for the week, there was something on primary, secondary, and tertiary healing of wounds. So this is an important concept that you need to get down. So that's why I was trying to play this for you, but apparently you can't hear it. So what I do want you guys to do, if you can, at some point today, go to Picmonic and look at this. So you remember you can get into Picmonic through me because I have an account there. So you just go to picmonic.com, and when it says to log in, you would put my email address, so jsilk@herzing.edu, and then the password is just October 25th with a capital O. So anyway, when you get in here, remember there's on the left-hand side, there's this, there's like a search, a browse, a playlist, home, all that. So go to playlist, and then this stuff is under adult 1. There's 3 million different things that I have saved in there. And then again, this is just called types of wound healing. So anyway, even if you don't like Picmonic and you don't like to listen to these things up top, I think these things at the bottom are kind of beneficial. So it does show you what it looks like the difference between the different kinds. So remember, with primary intention, it's going to be a wound, like say you go get, I don't know, your appendix out or something, and they do like an open procedure, and then you have sutures or staples that close up your incision. So I don't know if you can see up top here this picture, but up top it shows, okay, they make this incision and then they close it up. So they have actual staples or sutures there. So that's well approximated. And then if you look down here, it says, you have minimal scarring afterwards. You have, it really heals up well, and usually it heals pretty quickly. So that's primary intention. And again, approximated edges mean that you're bringing everything together so it's officially closed. So secondary intention is more, it's different. I don't know if I can find that. So up at the top here, they were talking about it's not approximated, it's open. So if you can kind of think of maybe maybe like a pressure ulcer wound that's pretty bad. So one of those types of wounds, sometimes you can't heal those by, just stitching it up. It's not going to heal right. So this type of wound, you're going to keep open and it's going to heal over time. So it's going to take a lot longer and you're going to have to wait for that granulation tissue to fill in. So that's kind of what this one would be. So these would remain open, they're not closed. Healing occurs by granulation tissue. You end up with a scar, unfortunately, after that heals up. And then the wounds are at higher risk for infection because they're technically open, and over time that will close up and it'll heal up. It just takes a while. So then tertiary intention is going to be a wound that is intentionally left open. And this is what people usually have a hard time understanding. They get these two mixed up, secondary and tertiary. So the difference between the two, you don't have an infection yet with secondary, but tertiary, you have an infected wound. It's open and it's deep. So I guess to remember tertiary, maybe think of someone, here's an example. So think of this. So maybe there is someone who is getting an amputation, like say they're getting their leg amputated, and they're getting this because they have gangrene there. So you think to yourself, okay, well, I'm just going to cut off the gangrene and they won't have it anymore. But sometimes it's so bad that surgeons will actually leave that open for a couple of days after they get rid of that leg. So instead of closing up that stump like they normally would, they leave it open so that that infection kind of can drain out, and they're really they're really sure that they got all of this gangrene out of there. So they would bring them back to surgery a few days later and close it up at that point. So that's kind of what tertiary intention is. So remember, secondary intention, you never close it up. It eventually closes on its own, filling in with granulation tissue. Tertiary, they actually will leave it open, but then they'll bring you back later on and close it up. So this wound is usually contaminated. It's usually, looks bad because it's infected. It's inflamed looking. It looks crummy. Does that make sense? Yes, no?
Yes.
Okay. So I just want to make sure I talked about that with you today, because I know in the past when I've had stuff like this on tests with people, I feel like they always get those two mixed up. So just make sure you really take a good look at this topic, at least. All right, another thing I wanted to talk about is, let me see if I can find it. There we go. So the inflammatory response. So when you think about the inflammatory response, you should be thinking about, okay, maybe you have some type of opening in your skin somewhere and you get some foreign body in there. And so this foreign body is causing this inflammatory response to happen. So your body kind of mobilizes everything together to try and it recognizes that this is a foreign particle that's in there and it wants to get rid of it. So it sends macrophages, there to try and get this foreign object and get it out of there. Your surrounding tissues start to get inflamed and red. You start to get more immune cells and things there to try and deal with this. So I just wanted to kind of mention the inflammatory response, because that is something too that's kind of, big in your topics for this week. So remember, we did talk a little bit about immunity last week. So this kind of goes hand in hand with that, this inflammatory response. Okay, so there's a couple of different topics. Let me stop sharing this a second. There's a couple of different topics that are pretty big for this stuff this week. So one of those things would be, the different kinds of wounds, the stage 1, stage 2, stage 3, stage 4, all of that. So I know we've had this before back in Intro to Clinical Nursing. What do you guys know about stage 1 wounds? Tell me what a stage 1 wound would look like.
Red.
Okay. Is it open?
And at times the skin
No.
is intact.
Okay, the skin's
Mm.
intact. That's important to know, definitely. Does it blanch or do anything like that?
Blanchable?
No,
What's that?
It's a non-blanchable.
No blanchable. Okay. So what's a stage 2 look like?
Open skin?
Stage 2 is going to be open, right? So this could be like even blisters or whatever you could consider a stage 2. But typically that top layer of skin is off and you have an open area now. So it's different than stage 1. Do you usually have any kind of drainage or anything going on with stage 2?
no.
No.
Okay. What's the difference between stage 2 and stage 3?
Stage 3, you see subacute tissue, fat tissue.
Yeah, so now you're starting to get into the fatty tissue, so you're getting a little deeper. Stage 2 is a little bit superficial, so you're not very deep. But stage 3, now it's getting a lot deeper, so it's getting into that fat. And then what would stage 4 be?
Bone and tunneling.
Yeah, so you could see bone or muscle now. So now we're super deep. We're down into the really deep tissues. All right, and then what is a deep tissue injury? What's it look like? You guys remember that one or no? Deep tissue injury looks like a bruise. Like it's like like a purplish color or whatever. It looks dark. Doesn't it's not like a necrosis or anything like that, but it just looks like you're bruised in some area. And then unstageable is what?
Eschar.
Yeah, so this one you actually have that black tissue there. And so typically you can't tell what stage it is. So that's why it's unstageable. Okay. So that's something that's really big in this stuff. Then who is more at risk for pressure ulcers?
I'll say the elderly, older age.
Okay.
Also, I was going to say babies, but no.
Diabetic patients
Okay.
and patients who are bedridden.
Okay.
Obese patients.
Obese patients, yeah. Really, there's kind of a big list of people we could say here, right? So just kind of keep that in mind. There's quite a few types of persons out there that are more at risk. So like for test questions, you're going to have to pick that out. You know, they may give you a question that would be like, out of these four types of patients, who's more at risk for a pressure ulcer? You know, and then you'd have to pick that out. All right. You guys remember talking about dehiscence and evisceration?
Yeah.
Yes, I think so.
Okay, what's dehiscence? And does this happen like with any wound, or is it just in a certain area?
Isn't dehiscence when isn't it usually like with abdominal wound?
Yes. So it's a little bit more specific then, right? So it wouldn't necessarily happen on an arm or a leg or something like that. It's more, you know, in your abdomen area. So what happens with dehiscence is someone will cough or sneeze or do something like that that causes increased abdominal pressure, and that's going to make the wound open up. So like they might be well approximated at first, but then after they do that, all of a sudden the wound opens. So maybe their sutures or staples come loose and, you know, now you see opening there. What's evisceration? What's that mean?
Isn't that the one when, for instance, you have actually the internal organs coming out?
Yes, you're correct. So they kind of go hand in hand, right? So you would hope if you just dehiss that that's all it is and it doesn't get any worse than that. But if you get to the point where you have evisceration and things are coming out, that's a huge problem. So you as a nurse, if you ever see this, you never want to take it upon yourself to like push things back in or do anything crazy like that. So what do you do for this stuff?
You put wet, you just cover it with wet, what was that then again? I can't remember. And then get the doctor.
Okay, so there's a couple things I want you to remember. You're correct. You do cover it with like a wet dressing. It's going to be like a normal saline, right? So
Right.
you would hope that you would have, you know, gauze or something close by that you could just grab quickly and wet it and stick it over that. Now, the thing is, you want to keep it moist because, you know, you got your organs sticking out there and your organs don't want to be dry. You know, that's not a good thing. So you do want to keep it moist. But the thing is, you got to remember the patient is going to be having a hard time during this. So they're going to see it and then they're going to start going into shock. So your big worry is about your patient. So you want to stay with your patient, and then you would probably call out to someone in the hallway to call the physician for you. So what the physician will do is they'll take them back to surgery to fix that. So if it's just a dehiscence where they just open, sure, you would still call the surgeon or something, but they're probably not going to go to such extremes, right? So maybe they would come back, they would assess to see how bad this was, and if they needed to put new sutures or staples in, or if they needed to go to surgery or what. So it's a little bit more of an extreme with the evisceration. Okay. Let's see what else. All right, so with wounds, when we're assessing wounds, what are some signs and symptoms that might make you think that they're infected?
When there's like a purulent drainage, discharge.
Okay.
When there is a discoloration.
What do you mean by discoloration?
It's like red.
Okay.
Sorry, I'm printing, so I didn't want the noise.
You're
It's
fine.
either supposed to look either red or pinkish. If so, it starts looking any kind of purplish color or greenish, it's
Well,
infected.
I mean, I don't know if the wound would look green, but like the drainage might, yeah.
And
What
also
what
the
else?
edges.
If the
The-
patient is having a high fever, like above, is it 104?
Okay, so they might have a fever,
Swelling.
swelling. So if you went in and you were assessing your patient and you saw some of these things, how would you confirm that, yes, this was an infection?
If the patient has a fever and maybe like doing a culture test and
Okay, so a culture test probably could tell you if there was an infection there. That's a good thing to do. What's another like blood test that you could do that might confirm this?
is it white blood cell count?
Yeah, yeah. So if they had labs drawn that morning and you just went in and did your assessment, you see all these things that are kind of worrying you, you go look at your labs from the morning and see if they had a white count drawn. And if that white count is up, you know for sure then you have an infection going on, right? So that's kind of how that goes.
Okay, but
What-
so what would you say what would be the first thing to do in that situation? What would be the first sign? Like, let's say we had a question that asks for the first sign of an infection, like the most one, and they had all these options. What would be the very first sign?
Well, it's not going to ask you like what's the first sign of infection. That's nothing they'd ask you. It just wants you to be able to, and honestly, you guys, everything I'm asking you this morning is specific to your test coming up. So that's why I'm talking about specific things. So hopefully you're paying attention. So there's a specific question about this, and it talks about you go in, you look at your patient, and they have all of these crazy signs and symptoms. So it's asking you what you would do next to confirm that they had an infection.
Okay.
Okay. All right. What about if you went in and you saw someone that had a wound and they had a black scab over it? What would you do for that?
Since it has a scab on it, you can't really tell. So don't you have to necessarily take the scab off?
Well, you don't want to necessarily like pop that scab off because it can actually be painful to the patient to do that. You can cause some damage. So if they just have the scab there, you're just going to assess it really well. You're going to measure it and you're going to see if they have any drainage or anything coming out of it, because sometimes just part of the wound is covered with the scab and part of it's not. So you're going to really assess it well. That's all you're going to do. So you don't want to pop the scab off because you can cause some damage. All right, what if you had someone who had a wet to dry dressing on? What's the purpose of a wet to dry dressing? What's the purpose of that? What are we trying to do?
Aren't you trying to clean out the debris?
Okay. What do we want the wound bed to be like?
Moist.
We want it to be moist, right? So if you go in, like say maybe you have orders to change the wet to dry dressing every 8 hours or something. And so 8 hours has been up, so you go in and you go to change this wet to dry dressing. But when you go to take it off, it's still wet. Would you leave it on or would you still go ahead and change it?
I would leave it because isn't the point of the dryness to clean the old like previous, like, you know, like the point to wait for it to get dry is to clean like the old debris off of it.
Yes,
So if
exactly.
I pick it up while it's still wet, I'm just leaving the old stuff on there still.
Exactly. That's totally correct. So typically, the wet to dry dressing, if it gets dry, then the idea is when you go to take it out, that you pull out some of that junk that's in their wound, in the wound bed. So you want to see like the nice red granulation tissue. And sometimes they have a lot of like, slough or junk like that that's in there. And if that wet to dry dressing can be dry and like take some of that off when you take it out, then you're better off. So it's doing what it's supposed to. Does that make sense?
So in that case, you do not change the dressing. Is that what you're saying?
Yeah, you would leave it because it's still wet. It's still moist.
Okay.
So the whole point in a wet to dry dressing is you put it on wet and then you let it get to the point where it gets dry so that when you take it out, that you're getting some of that junk out with the dressing. Because you know how like dressings will stick to a wound? So you can imagine this will stick to that wound, and as you're taking it out, it's going to get some of that junk out of there, and you'll be left with the good tissue. Okay? All right, I do want to go over a couple other things too. So that's pretty much the gist of this week because really you only had those 3 topics and it's all stuff that you've pretty much done before. It's pretty familiar. So there's really not a ton to talk about this week, for wounds. So for you guys, I just went over everything you need to know for this, okay? So you need to review in your ATI book that I told you about, your Fundamentals ATI, Chapter 55. That will tell you all about some of the stuff that is in these questions, okay? Then I just want to kind of review some of the other stuff from last week to make sure we're all on the same page with that as well. So we're kind of in a good place for, next week when we go to that harder stuff. Okay, so remember last week we talked a little bit about HIV. So with HIV, we said, so it's all about this virus attacks your immune system, right? And so your immune system is essentially really low and you end up, getting really sick. And eventually if you don't have treatment, you can end up getting something really minor like a pneumonia or something. And that might be what does you in and kills you, right? Because your immune system is so low. So do you remember when we talked about CD4 counts? What's a CD4 count?
I thought that's just what are infections. So if it's really low, then like you're more susceptible to like infections and stuff.
Yes, you're right. If it's low, you're going to be more susceptible. But what is the CD4 cell? What is that?
White
What's
blood.
what's it do?
Doesn't it help us fight infection?
Yes. So for someone with HIV, they always check those CD4 counts because really we have these specific cells in our bodies that they'll go after something that's foreign in our system, right? And so we want to have a lot of these so that, when we have all of these crazy foreign things in our body, these can go after it and help keep us well, right? So with a CD4 count, then, remember we said there's 3 stages of HIV. So that first stage, you may have like those flu-like symptoms and you may not even realize that you have HIV and you could be spreading it to all these people. So at that point, your CD4 count probably isn't super low, but then stage 2, it could start getting a little bit low, right? And then stage 3 would be your full-blown AIDS, and this is when your CD4 count gets pretty low. So do you remember the count that would be with stage 3?
Was it less than 200?
Yes, less than 200. So just kind of remember that, less than 200. That's kind of important. All right, so if we know that our patient has HIV, what's one of the most important things for this person to do to be able to stay healthy? So remember we talked about those medications that they take, right? Those antiretrovirals. So it's super important to take those like they're prescribed and to not just stop taking them. So, that's one of the biggest problems with this medication. A lot of times people will have things that happen, maybe they can't afford it or they have all kinds of crazy side effects. So they're like, heck with this, I'm just not going to take it. So if you don't take it, you're not going to be able to do well. The whole point in those medications is it prolongs your life. It will make sure that your CD4 count goes up, that your viral load goes down, that you're not like passing this to other people. If your viral load is really down, your chances of passing it to someone else is going to be really low. So you want to be on those medications so that you're going to be well. Does that make sense?
Yes.
So it's just like adherence to these medications is kind of bad. So that's a big, important thing to know. And then when someone who has HIV, like say you work in this clinic and someone comes in and they are newly diagnosed with HIV, one of the things that you would want to do with them is to do some prophylactic medications because this person is at risk for a bunch of, infection, right? So what would be some prophylactic things that you might give them that would help keep them well? Think immunizations.
Oh, is it pneumo something?
Okay, so the pneumonia vaccine, sure.
Yeah.
What else?
Hepatitis B and C and influenza.
Yeah,
Yes.
yes, for sure. Those are the things we would want to make sure they have because that's going to help protect them even more, right? Because they're going to be really at risk for that stuff. Good job, Vera. That was good. All right, and then we mentioned a viral load. What does the viral load mean? So the viral load is just the amount of that virus in their system at the time. So when I first get diagnosed with HIV, I may have a huge viral load, right? So, this HIV is in my system and it's multiplying like crazy, and I have a ton of it in my system. But then over time, as I'm getting treated with these medications are helping and it's making my viral load go down, right? So the amount of the virus in my system, sometimes it's really tiny and maybe hardly even detectable in your system. Now, what I do want to say is you never are at a point where you don't have HIV anymore. You always will have it still. So even if your viral load is undetectable, which is great, that's what we want it to be, doesn't mean that you don't have the virus anymore. You still have it and you always will until they come up with a cure, you know? So just remember that about viral load. There's a specific question having to do with that where you just need to have an understanding of what it means so you can you can answer that correctly. Okay, so there's another question having to do with antimicrobial resistant organisms. So you know how like if someone doesn't take their medications fully, like, you know, say you have, I don't know, C. diff or something, and then you quit taking your meds at a certain point, you don't fully take all of your antibiotics or something, and then you get it again, and now it comes back with a vengeance, and it's hard to get rid of. So what are some things that we could tell people on how to not get antimicrobial resistant organisms? What are some things people could do to prevent that?
Adherence.
Okay, so taking the full amount of their medications like they're supposed to. Any other thoughts?
Getting the tests done. Getting tested as often as.
Okay, let me find my thing real quick and I can comment more on this. Did you ever hear of someone like, I don't know how much you've ever heard this before, but sometimes people are crazy and they'll go and they'll be like, oh, my mom just got done taking such and such and she didn't take it all, so I'm going to take some of that now. And they'll take someone else's medications. That's kind of what this is getting at, to like not do that kind of stuff. Let me find this specific question so I can tell you better. Okay, so the question itself, you're trying to educate people about these antimicrobial resistant organisms. So, you know, what kinds of things would you say to someone so that they don't have this happen? So the thing it's saying, you should include information about how to properly use antibiotics, which will help decrease the risk of antibiotic resistant infections. So yes, take your antibiotics the full amount of time that you're supposed to. You should never take leftover antibiotics, you know, that are someone else's, because they may not be the appropriate antibiotic for your current illness, and they could lose effectiveness over time. Because, like, I know my parents are like this. They'll keep medications in their cupboard forever. So, like, they could have something in there from 5 years ago, and they still haven't gotten rid of it. So that's kind of a concern as well. You don't want to like keep a hold of things. You get rid of them, you know, when you're done. Because medications lose their effectiveness over time. So if it's old, it may not work as good as it should, you know? So that's something you should be talking about. And then of course, like if you have a virus, you know, if it's specifically a virus, can you take antibiotics for that?
No.
No, you cannot, right? So antibiotics are specifically for bacterial infections, not viruses. So that's another point that they're trying to make here. So like, you know, the lay person out there, sometimes they just reach for whatever they think is going to help, and it's not always the best thing to do. Now, hand washing is always a good thing to do, but it doesn't always prevent this type of infection. So that wouldn't necessarily be helpful here. But yeah, so those are kind of the main things to know with that. Okay, so there's one other thing. I'm going to split you guys into groups. Let me get back on my thing here. I just want you guys to be in groups of 2. And I'm going to give you a couple of things to investigate and then come back and we'll talk about. So how about we do Lisa and Vera? I want you guys to look into anaphylaxis. I want to know specifics about anaphylaxis, like what kinds of signs and symptoms do you specifically see with it, and how should you treat it? Like what, if someone goes into that, like if you're in the, out in the community or something, and someone goes into it, what should you do? Whereas if you're in the hospital, how do you treat it there? There's a bunch of things you can do for that. So I want to know that from you guys.
Okay.
All right. And then Cynthia and Aman, I want you guys to look specifically into like allergy testing. So you know how people can go to their allergist and get allergy testing, right? So I want to know specifics about that from you two. And I want to know like what kinds of things you would watch for, if you were the person who's working in this clinic given these allergy tests. What are some safety measures that you would have to take when you're giving these allergy tests to these people? Okay. Then Gloria and Stella, I want you guys to look into, there's a specific disorder that's mentioned in one of our questions on this next test, which I don't know that you guys have ever talked about before. So I want you guys to look it up right now. It's Guillain-Barré syndrome. And
Can you spell it, please?
Yeah, I'll spell it for you. It's Guillian, and then the next word is Barre, Guillain-Barré syndrome. So I want you to look that up, and when you come back, you'll tell us what it is, and then I want you to tell us, look specifically into the possible causes of that, because that's kind of what your question is getting at. So specifically about causes. And then Krishna and Tanisha, I want you to look into contact dermatitis a little bit. Let me look at that question real quick so I can give you more specifics about what I want you to look at. Okay, so with contact dermatitis, I want you to look into like how this person would present if they had it, and then how would you figure out maybe what is causing it? That's what I want you to look into. So just take like, it looks like it's 9:43 right now, so maybe take like the next 15 minutes to answer these questions and then we'll come back. Let me see if I can put you into those different breakout rooms. You guys who are still in here, you know how to get into your breakout room?
Hey, Miss Silk.
Yeah.
For some reason, I was in a breakout room by myself. I don't know who I was supposed to be paired with.
Oh, Aman was supposed to be with you, Cynthia.
Oh, she was not there. I was just there by myself.
Oh, well, she's sitting in here, it looks like, so.
Okay. What was our topic, please?
I told you guys to look into allergy testing.
Okay, got it. Thank you.
Mhm. Okay, let's see. 1, 2, 3. I'm missing one person, I think. All right, so I gave you guys a couple of things to look into, so I just want to see what you guys came up with. So who wants to go first?
I will.
Okay. All right, what'd you have, Tanisha?
We had contact dermatitis.
Okay.
And so you asked how would it present and what's causing it. So with the how does it present part, we said it may look red and swollen with small fluid-filled bumps, and it occurs within a few hours of being exposed. And when it rash appears like eczema when it's chronic, and the skin may thicken, scale, or crack from scratching it. And just some symptoms that somebody may have with it are like burning and stinging, swelling or peeling. Um, and just like if you have an allergy to like rubber gloves or something, you'll have hand dermatitis. And then you said what's causing it. So um, we put, sorry, I'm trying to pull it up back on my phone.
Oh, you're fine.
We just said that the location of the rash depends on the allergen exposure. So some you can get it, like they gave an example, but I didn't really use that one. But it's just some places is like under the belly button or like earlobes from earrings or like around your neck from your necklace. Cosmetics, you can get it on your face and eyelids. Um, yeah, stuff like that.
Okay.
And then we did write treatment, but you didn't ask us for that. But we
Okay. Well, you can say that. Go ahead.
for some treatment, like for smaller acute symptoms, you can cold compress to help with like the itch. But if they have like oozing, you could use like the calamine lotions or oatmeal baths and stuff. And if you have hand dermatitis, don't wash your hands that much and like use mild soaps and moisturizers with no dyes or like scents and stuff. And you always should wash your hands after contact with the allergens just so it don't spread or stuff like poison ivy and stuff because like it's real severe. And just use like antihistamines and topical steroids and stuff like that.
Okay. So the particular question on your upcoming test that has to do with this. So in the question, it tells you about this person that is presenting to your clinic or whatever, and they present with all these crazy symptoms. So you're going to think, okay, this is contact dermatitis.
Hmm.
And it says something about how are you going to figure out what caused this? So what would you do in your assessment to figure out the cause?
Um,
Which I don't know if you read very much about this, but it's kind of a weird question. I think that's why I gave it to you because I don't know if anyone would get this otherwise. Let me find it specifically. Hold on one second. So it says, which of the following questions would be most appropriate for the nurse to ask the client to help determine the cause of the skin condition? So what do you think you would ask?
Probably like what were you doing before you got the rash?
Okay.
Or like um did you put on any like lotions or something that you didn't put on, that you haven't used before?
Yeah, and typically a lot of people will ask stuff like that. But for this question, it's saying, what do you do for work? Because
Oh,
there's,
that's the answer?
yeah, yeah,
Oh.
because they're saying that maybe that's a way you could figure out how they were exposed to whatever it was, you know?
Well, that would
Oh.
kind of make sense.
Wait, so what do you do for work? The which geared you to contact, I mean, to get that reaction?
So
Yeah, that doesn't make sense.
I
That's
know.
what I'm asking, because I'm like, huh?
So apparently, chapter 13, page 200 is where this is coming from. So they say contact dermatitis is caused by exposure to a physical or chemical allergen, such as a skincare product or cleaning product or latex gloves. So your initial symptom would be itching, redness, and raised papules occurring at the site of exposure, and it can begin within 1 hour of exposure. The best question to ask, what the client does for work, is going to help you figure out what the client was exposed to and that what caused the dermatitis is what it's saying. Like the other options, I'm not going to tell you the other options, but they just don't make sense.
But like that happened to me one time because when I used to work at the nursing home, we got this new cleaning spray and I had accidentally got some on my arm and instantly like my arms started to turn red, and then I got like these raised bumps and stuff. And when I went to the doctor the next day, I told them what happened, and she was like, well, I was going to ask you what you did for work.
Yeah.
So
Yeah, I know it seems like a weird question, but just so you're more focused at looking at that, I just wanted to tell you that. Okay, good job, guys. All right, who wants to go next?
We can go.
Okay, go ahead, Stella.
So we had the GBS, which is Guillain-Barré syndrome,
Okay,
and we found that it is an immune system attack
okay,
where healthy nerve cells, the immune system attacks the healthy nerve cells in the PNS, nervous system. And you said to find what the causes are. So according to CDC, there's no actual cause.
hold on, before you go any further. So what do you see with this Guillain-Barré syndrome? How's it present? Did you look at that at all?
Yes. You get like tingling or prickling sensation in the fingers and toes, muscle weaknesses, difficulty walking steadily, fast heart rate, difficulty breathing, paralysis, and a lot more.
Yeah, so basically it's like a progressive paralysis that moves up your body. So it's very scary. So I just want to make sure you guys are all aware of what it looks like, because it's not something that you see every day, but you could see it for different things. Now go on with your cause stuff.
Yeah, so like I was saying, CDC says there's no actual known cause for this syndrome, but that people usually get it after they've had like diarrhea or respiratory infection. They also mentioned that Campylobacter, which is the most common bacterial cause of diarrhea, or most common bacterial cause of diarrhea in the United States, that has been associated with the syndrome too, as well. They also said that infections such as influenza, HIV, and AIDS has been associated with the syndrome itself too.
Okay. So here, let me share this real quick. So yeah, this is just like Mayo Clinic here, is all I'm on. So basically for causes, it's saying, again, like what you said, there's not like an exact thing that says, yes, this is what causes it. But usually something happens to your immune system, like you're sick with something beforehand, and then all of a sudden you get this, right? So look at risk factors here. So there's a huge list of things. So here's that bacteria I think you were talking about from undercooked poultry, influenza virus, cytomegalovirus, all of these things, right? So for your purposes, now when you have this question on your test, it says something about, here, let me look at it. Where is it? Oh, no, I can't find it. So it's something about this person was sick just recently with the flu, and now they get this Guillain-Barré syndrome. So you're supposed to pick out that the flu is what caused it, is what it is. Or here it is. So you're getting an admission history from someone who has Guillain-Barré syndrome. Which of the following should the nurse expect to find in their history? So because they have this Guillain-Barré, it's going to list some things, and you're going to be like, oh yeah, that could possibly have set them off into getting this, you know? So that's kind of what it's looking at. I wanted to make sure I went over this because I didn't think that was a very fair thing to ask you guys, because you've never talked about Guillain-Barré. Now, this is in your chapter 13, which I don't know if you had it in your Realize It stuff at all. Did they talk about that? Do you know?
I do recall seeing it. I don't recall seeing that at all, to be honest.
So it's supposedly in chapter 13, somewhere around page 204 to 205, somewhere in there. So they just talk about, remember chapter 13 has to do with all of that immunity stuff. So that's why they mention it in there. Now, Guillain-Barré is not necessarily like an immune thing, but that's what can like set it off, you know? So anyway, that's what that one's about. I just wanted to make sure you understood that. All right. What was the other stuff we were going to talk about? So we did that. We did that. How about anaphylaxis? Can you guys tell us about some anaphylaxis stuff?
Yeah.
Okay.
Okay, so it says it's a severe potential life-threatening allergic reaction, and then it occurs within seconds or minutes. So the way it happened is your immune system release a flood of chemicals that cause you to go in shock, and your blood pressure drops suddenly on your airway while blocking your breathing. So some signs and symptoms of anaphylaxis is weak pulses, skin rash, nausea and vomiting, and it's rapid. Also, some things that can trigger it are certain foods, some medication, insect venom, and latex. So the treatment for anaphylaxis, epinephrine auto-injector. And also he asked about what will happen if someone is to get it outside. It says that you have to see if the person have an epi with them, and then try to keep them calm, inject the epi, and then call 911, and also help them lie on their back and raise their feet about 12 inches and cover them with a blanket if there is one. So
Oh,
it
one
also
of
says,
one of the things that you didn't mention with signs and symptoms with anaphylaxis, you can have a low blood pressure with this as well. So what your thing you were just talking about with putting their feet up, that's why you do that, to help get the blood back up to their head and get a better blood pressure.
okay. So and then it also says turn them on the side if they are vomiting or breathing.
Okay.
And then make sure that their clothing is loose so that they can breathe. And then at the hospital, it says call for help, and then give an intramuscular injection of epi at the earliest, and then followed by IV or IM epi injection. And then place them in a supine position with the lower extremities elevated. And also check their breathing and give oxygen if needed. And importantly, like stop any infusion of suspected medication that have caused the reaction. And then it says volume resuscitation with IV fluids.
Okay. So yes, the most important thing to give for anaphylaxis is going to be your epinephrine. That's the most important thing every time. So when you're outside in the community and you have someone that has some kind of attack, yes, you see if they have an EpiPen and you give that. Now, have you guys ever looked at an EpiPen, what it looks like?
Yeah.
So
Yeah.
when you open that up, it actually has instructions on it, like what to do. So it's kind of nice. It's very user friendly. So if you had no medical experience whatsoever, you could just follow the instructions and do what it said. Now, you don't want to screw around with like trying to remove clothes to get to an area to, give them this injection. So you do it right through their clothes. So like, you know, where would you give that? I forget what you guys said. Did
What
you
was your
mention it?
question again? Where did you do what?
Where would you give that EpiPen at?
The thigh area.
Yeah, so like if they had pants on, you wouldn't screw around with messing with that. You would just go right through their pants into their leg.
Mm-hmm.
And then another important thing that a lot of people don't remember about Epi is, you know, like especially out in the community like that. Yes, you did something to help, but they may not be out of the woods yet just by getting that one dose of Epi. So they definitely have to go to the hospital regardless if they feel better or not, because they could still be having issues. Okay.
Mm-hmm.
Now, the other stuff about, you know, if you have someone in the hospital setting that has anaphylaxis. So yes, you would give epinephrine in the hospital too, but there's other things that you could give as well. So think about it, you know, if you're having their airway cutting off, what are some things you would want to do for that to open up the airway? What's a respiratory med we could give to help with that? What's the breathing treatment that we give pretty much everyone to open up the airways?
The albuterol.
Albuterol, right? So you could see them get that. And then again, you know, if they have all this swelling going on, what's something that we could give through the IV to help with swelling?
Can you give them Benadryl?
Yes, you can give them Benadryl.
I know, because I was given Benadryl when I had all the swelling.
You could definitely do that. But what else could you get? You could give a steroid through the IV, right? Because the steroid is going to help with that as well. And obviously you wouldn't keep them on that, you know, that would just be, you know, for this situation to get them through, right? So those are some other things to think about with that. I just want to make sure we talked about anaphylaxis. You do have a few questions having to do with that. There is, let me see. There's a couple of questions actually, but they're just worded differently, that's all. Like the one is specifically, you know, wanting you to pick out epinephrine, which I think you'll have no problem, right? And then there is another one. So if someone has a hypersensitivity reaction, a type 1, it says, which of the following would be the best action for the nurse to take? What would you do if they had a hypersensitivity type 1 reaction? What would you be worried about?
Airway?
Okay. So specifically, we're worried about anaphylaxis. So
Right.
you're going to implement emergency treatment for anaphylaxis for this, right? So that's one of the other ones on this. Okay, good job, guys.
Okay, thank you.
All right, I think we got one more group. So we wanted to know about like allergy testing, I believe. So can you guys tell us about that?
Yep. For allergy testing, the 3 tests is usually done: a skin test, blood test, and elimination diet. For the skin test, there are 3 types of specific skin tests the doctor orders for. One is the patch test, 2 intradermal test, 3 scratch test. For the patch test, the doctor usually uses an adhesive patches. The patches will remain on your body for about 48 hours. Then they're gonna check you again after 72 to 96 hours to see if you're allergic to whatever antigen or allergies test they were doing. For the intradermal test, the test requires injecting a tiny amount of allergen into the dermis of the skin. And for the scratch test, an allergen is placed in a liquid. Then that liquid is placed on a section of the skin with a special tube And if there's like redness, swelling, elevation, or itchiness, that means you're allergic to the specific a specific allergen. The second test is the blood test, and the blood test is done in the laboratory for the presence of antibodies that fight specific allergens. And this test is called the ImmunoCAP, and it is very successful in detecting IgE antibodies for major allergens. And the last test is elimination diet. For elimination diet, this helps determine which foods are causing you to have an allergic reaction. And usually the doctor takes out some specific foods and then have you eat like a specific food, and for like I think 3 to 5 days, to see if you're allergic to that specific food. Then later on add different other foods to test for allergies.
Okay. Did you, I don't know, have any of you guys done allergy testing before? Like, have you had it done for yourself, or do you know anyone in your family that's had it or anything?
Yeah, years ago they inject a bunch of stuff on your skin and wait to see a reaction and see what you're allergic to.
Yeah.
Unpleasant stuff.
Yeah. So my husband did this a few years ago. They did the skin testing, and he had like a bunch of areas on his back, and I think on his arm too, they did it. But yeah, so he wasn't allowed to take any antihistamines or corticosteroids for like 48 hours beforehand. And because of that, he was just miserable, before he went to get tested. And then they do this, and then your skin just erupts in all these crazy places, and it's horrible. So that's specifically for when you're trying to figure out what someone's allergic to. But then, like, if someone comes to your allergy clinic and they want to do like these allergy shots to kind of get them immune to whatever this allergen is, then you can do that as well. So I don't know, did you look at that, Cynthia? I don't know if you got a chance to look at that.
No, I didn't go deep into that.
Okay, that's okay. So with that, like, say I'm allergic to, I don't know, pollen or something. So we constantly have a ton of pollen in our area, and I just want to get immune to that so I don't constantly have that problem. So I go to my allergist, and they inject me with a little bit of this pollen over time, like all the time. So when I'm there at the office, what would you be worried about as you're doing these injections with this person?
Like they will have an allergic reaction.
Yes. So you should always have, your emergency equipment close by just in case. So it's kind of, in a way, it's kind of a risky situation, but over time, as you keep getting exposed to it, over time, it gets a little bit less and it's not as bad, right? So you guys have a question that's something like that. Yeah, so it's a select all. So like you go and you're going to this allergy clinic to get this immunotherapy for your allergies. And it says, what information should the nurse include in the teaching? So what's another thing that you would think that you would have to do when someone comes to your clinic for this testing? That would be kind of like a safety thing.
Can you rephrase the question, maybe?
Okay, so again, you have this person coming to your clinic to get these injections for their allergies, right? And they're coming over so many weeks' time, to keep getting these. So while they're there, what would be something that you would do to help, like a safety thing that you would do to help prevent, further problems? So like we just said, we're giving them little bits of this allergen constantly. And so we would be afraid maybe they'd have a reaction of some sort. So would we want to keep them for a certain amount of time after they get this injection?
Yes.
Yes.
At the same time.
So after you receive your dose, you should be observed for 20 to 30 minutes. So they have to stay there so you can watch them and make sure they're okay. Other things that you would teach this person as you're giving them all of this allergy stuff. Obviously, if they know what they're allergic to specifically, which they should if they're getting allergy shots now, they need to stay away from that. So just try and stay away from that as much as possible while they're getting all of these shots. Also, during this time where they're getting these injections, make sure they tell the person who is giving them these shots if they start to get itching or dizziness or sneezing, any like weird symptoms like that.
Wait, what did you just say?
So they need to make sure they tell the person who's giving them the shot if they experience any kind of itching or sneezing or dizziness or anything strange like that after they get the shot. So that's kind of what that question's about. It's just about, you're trying to get immune to this allergen, and what kinds of things would you want to make sure that you do, to educate them about this. And again, this is in chapter 13 in your Lewis book. All right, real quick, do you guys know what an autoimmune disease is? What does that mean?
Is it like your body can't fight infection anymore, or you keep getting infections?
No, not really. It's
Is that
more
like your body attacks, like your own body attacking you, like?
yeah,
Themselves.
your body's kind of attacking itself in some way. Yes.
Yeah,
Because
like
I
I
know
know.
the thing that we just looked at, the GBS, is an autoimmune disorder.
Yes, you're correct.
Like I know lupus to be an autoimmune disease.
Yes. What are some other ones you can think of?
Celiac disease.
Arthritis.
What's that?
Rheumatoid arthritis.
Yes, that's one.
We also have MS, multiple sclerosis.
Definitely.
We have
Celiac.
the IBD, the one we studied last semester.
Anything else?
Psoriasis. No.
So there is a specific box in your book. I think it's not sure what page. It's like somewhere in 204 to 206 in that area. There's a box at the bottom of the page, and it talks about autoimmune diseases, and it lists a ton of them. You're going to specifically have a question about that. So you need to know like multiple types of autoimmune diseases. You just need to know which ones there are.
So it will ask us to select all of,
Yeah.
Okay.
All right, so I tried to go over most of everything that we have talked about so far. I think I got through quite a bit of stuff. Oh, what's the difference between a systemic infection and a local infection?
Systemic is the whole body. Local is specific, like a body part, something.
So if I have a local infection, that means that what am I going to see at that site?
Swelling,
Swelling, pain.
pain, stuff like that. But systemic, you have like fever.
Yeah, so systemic, it kind of gets into your bloodstream and it spreads to other areas, right? So it's a little bit more severe. Okay. All right, I think I got through most of this, you guys. I won't keep you on here for any longer. So the next week we get into some more difficult topics, I think. Like what we've done so far, I don't think it's been too bad, but next week we get into some of the endocrine stuff, which a lot of people tend to have a hard time with. And then a little bit about fluid and electrolytes and stuff. So that's kind of going to be like the last little bit of stuff before our next test, I believe. So we'll go over that as best we can and see what we can do with the rest of this, okay? I will give you a tips to know again for the test. And honestly, I went through a ton of it with you today, so you should be pretty good for this stuff.
I have a question.
Yes.
So you gave us an ATI chapter for skin. What chapter is it on a regular test book?
For the skin stuff, it's chapter 11.
Okay.
Yeah, so I posted the PowerPoints already. They're in your module under module 5. So there's 3 PowerPoints there for chapter 11 that you guys can take a look at as well.
All right, thanks.
All right, any other questions? Do you feel better about this stuff or not?
After I take the test.
After you take the test, you said? No, I want you to know it, I don't want you to feel like you're just trying to learn just so you get an okay grade on the test. I want you to know the information. So hopefully you're kind of getting there. The stuff that we talk about next week, some of it will be review and some of it will be new. So just make sure you really spend some good time on that stuff because that stuff's a little bit more difficult.
So it's only 3 chapters?
What is?
The exams.
Well, I think last week we had 2 chapters that it was over, and then this one was another one, so chapter 11. So that's 3 chapters that we've gone through so far. And then next week will be, whatever chapters that is. I didn't look ahead that much to see what chapter that is.
Are all our exams from this semester about to be realized at exams?
For this term, yes.
And were you able to check the time for the exams?
Yeah, I'm going to email someone about that today to see what I can find out, to see if I can change that. Okay. All right, so we're going to meet again for lab, probably 12:30. I think today we go over central venous access devices, so we'll talk about that for a little bit. Any questions about that stuff before I get off of here?
Not yet, but then when I go read everything, probably when we come back, I'll have some.
Okay, that's fine. So remember your stuff that you turn in for this week, I believe I made this ATI. So you would have to go and do your module on ATI, and then whatever you do, you would have to print out that and turn it in.
Okay, I had a question on that. So the one that we turn in for the module on ATI, you have a section for it, right, for the submission?
I'll look when I get off here to make sure.
I saw it.
If I don't, I'll put one up there real quick. That's no big deal.
Okay.
Okay? All right, I'll see you guys in a little while. Thanks.
Bye.